Welcome to the part 2 of head injuries and medical legal aspects, and it discusses about brain contusions, lacerations, concussion, raised intracranial pressure, diffuse axonal and diffuse vascular injury. Before going into much detail, I just want to emphasize that I am going to cover a very basic aspect for undergraduate level. Actually speaking, neuropathology contains very complex understanding. To start with, classification of head injuries. There are many methods. However, I am going to describe only three methods. Whether the injury is open or closed in nature. Open means whenever the injury penetrates the scalp and skull, such as in gunshot, stabs, and complex road traffic injuries with open fractures, we get open type of injuries. Then what do you mean by a closed type of injury? In this case, you don't get any scalp and skull injury, whereas you get inside injuries such as concussion, contusion, diffuse axonal injuries, and intracranial hematomas, epidural hematoma, and subarachnoid hemorrhages and intraparenchymal hemorrhages. The second method is based on whether the brain is affected focally or diffusely. Diffuse injuries, examples, concussion, diffuse axonal injuries, blast injuries, and as in shaken baby syndrome. Focal type of injuries are very obvious, as in contusions, penetrating or lacerations, as in hematomas in multiple forms. The third method is based on the time of the injury. That means if injury occurs at the time of the impact, such as in injury to scalp or surface contusions or diffuse axonal or vascular injuries, we are going to name it as primary type of injury. Whereas to that, if the injury occurs after a while due to the secondary effects such as hypoxia or hypoperfusion, resulting in cerebral edema or herniation, we are going to term such injuries as secondary kind of injuries. Having classified head injuries, let's study important types. What do you mean by a cerebral contusion? It's a focal bruise of brain tissue caused by trauma, characterized by small hemorrhagic areas, edema, and also with tissue damage. Usually, contusions are seen in the cortex, and if the force is strong enough, it may extend into the white matter as well. Fresh contusions may look like as streak-like or punctate blood extravasations. And the cortical lesions are often covered with subarachnoid bleeding as well. If the person is going to survive for a while, contusions undergo resorption of the necrotic tissues, resulting in cavitated areas with surrounding gliosis and hemosiderin staining of the adjacent leptomeninges. Examples for brain contusions: you can get brain contusions with direct trauma, Kondraku type of injuries, acceleration, deceleration type of injuries, fall from height, road traffic injuries, or sport-related injuries. The macroscopic appearance in detail, as you can see here, it may be diffuse or punctate. As you can see, punctate means small dot-like areas, as you can see here in the cortex. And when it is more, or the force is more, you can see in the white matter as well. Lesions are often wedge-shaped, as you can see here. The base of the wedge is on the surface, that means over the crests, and the tapering side facing towards the white matter of the brain. Brain laceration. With trauma, if there is a tear in brain tissue resulting in hemorrhage and damage, we can simply define it as a brain laceration. Here, importantly, we have to note that in contrast to contusion, the para-arachnoid membrane is going to get damaged, as you can see here. What do you mean by a burst lobe? Burst lobe means when an intracerebral hematoma bursts into the subdural space, leading into a little bleeding or necrotic tissue, we define it as a case of burst lobe, as you can see here. Now we are moving on to very important aspect in medical legal practice, coup and contra-coup injuries of the brain. What do you mean by a coup injury? It is a brain injury occurring directly beneath the site of the external impact, as you can see here. The usual scenario is the head is stationary in this case, whereas to the contra-coup injury, where you get a moving head, in this case, a stationary head is struck by a moving object, resulting in contusions or lacerations developed at the site of the impact. Then what's the mechanism? It's very straightforward, any form of direct blunt force trauma. Let's learn more about contra-coup injuries. Imagine a situation where a person falls backwards and he hits his occiput on the ground. No impact at the frontal region. However, at the autopsy examination, it was found that brain was contused at the frontal and temporal poles and underneath. What could have been the mechanism to cause such injuries that is away from the site of impact? Contra-coup injuries occur when a moving head suddenly stops, resulting in a sudden deceleration. During this sudden deceleration, two physical phenomena come into play. The first one is Newton's first law or law of inertia, and the second one is rebouncing of the brain. What is the law of inertia? It is the natural tendency of an object to resist a change in its state of motion. If the object is at rest, it likes to stay at rest. In contrast to that, if the object is in motion, it tries to be in the motion in the same speed and in the same direction. During the backward fall, where the occiput strikes the ground, the head stops suddenly, but the brain continues to move downwards due to inertia, causing a coup injury, as you can understand. Now this is the fall. With the fall, the head is going to get a sudden strike. However, the brain likes to move into the same direction due to the law of inertia. So here what you get, the coup injury. However, because of the hard nature of the skull, brain hits here and it causes rebound phenomenon. Now you can understand the brain moves upwards and it hits over the frontal pole and also over the base of the skull as well, causing contra-coup injuries. So this is the mechanism of causation of contra-coup injury. Now you can see here, now this is the typical appearance of contra-coup contusions on the frontal poles and also the underneath of the poles, and these are the frontal poles, as you can understand here. Now you know coup injury means under the impact, as you can see here. Contra-coup injury means just opposite to the site of impact. Imagine a situation where head hits on its sides of the head, or in other words, parietal areas. Can we get still contra-coup injuries? Definitely. There are two ways that we can get contra-coup injuries. Now, when the head hits here, still the brain can move this way and it can hit on the falx cerebri and getting unilateral side of contra-coup injury here. And also, brain can move like this and hit on the contralateral side of the parietal bone, causing contra-coup injury here as well. So this is another or two other ways where we can get contra-coup injuries. As you saw earlier, we can get injuries over the frontal and parietal. Last time I made a little mistake. So these are the temporal poles, you can get injuries over the frontal and temporal poles and also underneath of these folds. And also not only contusions. Sometimes in case of severe injuries, rarely you can get brain lacerations as well, and also you can get fracture of anterior cranial foci as well, since the base of the skull is really thin on that area. We described about Konjaku injuries. It is the brain damage on the opposite side to the side of impact. Usually occurs when head is mobile and strikes a stationary object. Brain continues to move within the skull after skull stops. The mechanism is actually deceleration, and then brain strikes on the inner skull inner aspect of the opposite side, and the mechanisms that we explain are inertia and rebound movements. So definition, you can read it up leisurely. This slide I am not going to explain. If you wish, you can read it at your leisure. Special features of Ku and Konjaku injuries. It is mentioned that sometimes a Ku injury may be absent, but there may be a large Konjaku injury. There can be Konjaku injuries even without external injuries in the forms of skull fractures sometimes. And also it is a known fact that Konjaku injuries most often affect the frontal and temporal lobes, especially at their tips and undersurfaces, as I have shown you earlier, and it can be symmetrical after a fall on the occiput. If I just draw a little picture here, if this is the brain and this is the frontal region and this is the occiput, if the person gets the Ku injury here, the person gets the symmetrical injuries over here. If the person gets the impact there, so you know the Konjaku injury gets exactly the opposite direction. So in this case, you get a very asymmetrical type of Konjaku type of injury. If the impact is here, you get only the Konjaku injury here. And at times, the damage can be severe with hemorrhagic cavities in the deep cortex and white matter, especially in the frontal and temporal tips. A frontal impact rarely produces occipital Konjaku. It is described that it is due to the cranial floor anatomy, and it is virtually unknown getting occipital Konjaku injuries. So now we always explain about impact on the occiput resulting in frontal or temporal Konjaku injuries. How about the vice versa? That means if a person gets a frontal impact but usually or not known about, resulting Konjaku injuries over the occiput. Cortical contusions and lacerations are the most reliable indicators of Konjaku type of injuries, and extradural hemorrhage is never a Konjaku type of injury. Temporal or parietal impacts can cause contralateral Konjaku lesions, as I have explained earlier, and even in unilaterally upon hitting over the falx cerebri. And now you can understand it's a very good thing that is very important in medical legal aspect. So as JMOs, we have to tell whether the injury pattern is compatible with a fall or with an assault. So now as you can understand, usually Konjaku injuries we get with a falling head. As a result, if we can see Konjaku type of injuries, we are in favor of a fall rather than a case of assault. Moving on to another important topic, brainstem hemorrhages. It could be either primary or secondary. Primary means it occurs at the time of impact, and morphologically it is well circumscribed lesion, sometimes rounded, which lies laterally in the tegmentum, and the shape of the midbrain or the brainstem is not going to be distorted. That means single small hemorrhage. However, whereas to that secondary brainstem hemorrhages actually is a result with the raised intracranial pressure damaging to the small vessels. So as a result, such hemorrhages are large and it tends to distort the shape of the midbrain, and it is termed as Durant hemorrhages or secondary pontine hemorrhages. Moving on to the step-by-step description of raised intracranial pressure mechanism due to a space-occupying lesion. What do you mean by a space-occupying lesion? A space-occupying lesion is any brain mass that displaces normal brain tissue, increasing the intracranial pressure along with the risking of herniation, and it is due to the limited space within the skull and also because of the rigid nature of the skull bones. And simply explaining, it is due to non-expandable area. What are the examples for space-occupying lesions? It could be anything. It could be a contusion, maybe a laceration, could be an EDH, as you can see here. However, the mechanism of raised intracranial pressure is a bit complex process. However, I described here is a very basic to cover the medico-legal aspects only. A sufficiently large space-occupying lesion compresses the surrounding brain tissue. It causes ipsilateral ventricle to be compressed, as you can see here. It results in CSF accumulation in ventricles, resulting in internal hydrocephalus. And also it causes to increase further to raise the intracranial pressure. Finally, the compensatory mechanisms fail to manage further. Such changes result in midline shift and also it compresses the third ventricle. The building of pressure causes an obstruction of the CSF smooth flow to the opposite lateral ventricle as well. It causes contralateral internal hydrocephalus, resulting in further increase of intracranial pressure. That means bilateral raised intracranial pressure. Because of the limited space within the skull, raised ICP is resulted in herniation of parts of brain through the possible areas. One such herniation is subfalcine herniation or cingulate gyri herniation, in which the ipsilateral cingulate gyrus of the frontal lobe is herniated under the falx cerebri, as you can see here. This may compresses the anterior cerebral artery, resulting in frontal lobe infarction, worsening the edema further, as you can understand. This causes to compress the perforating vessels, resulting in ischemic necrosis of basal ganglia, thalamus and hypothalamus, in which you can see central area herniation as well. The next herniation is the uncle herniation. It is a life-threatening brain emergency, as you can understand. Uncus is the part of the temporal lobe, and due to the raised intracranial pressure above the tentorium, as you can understand here, the uncle area is going to get herniated through the tentorial notch. So this is the tentorial notch where you can see uncle herniation. This herniation is further described as transtentorial herniation, and with this pressure, the posterior cerebral artery is going to get compressed, resulting in occipital lobe infarction, commonly known as calcarine infarction. With the pressure, the midbrain pushed against the tentorial edge, forming the Kernohan's notch, and that is the indentation of the cerebral peduncles due to the transtentorial herniation, where you can see this area. With these effects, the third and sixth nerve palsy could be the result, and it shows as fixed dilated pupils and lateral rectus muscle palsy of the eye. These changes are actually work as a vicious cycle, and finally, with further pressure increment in the inside, causes tonsils to get herniated through the foramen magnum. It compresses the medulla oblongata and further causes damage to the vessels inside and also infarctions, causing secondary brainstem hemorrhages here, leading to respiratory arrest and cardiac arrest. To summarize everything, any space occupying lesion that is adequate to raise the raised intracranial pressure causes the compression of the brain. It causes ventricular compression, accumulation of CSF, resulting in increased intracranial pressure. It causes midline shift and also the contralateral compression of the contralateral ventricle as well. Now, as you can understand, bilateral raised intracranial pressure is the ultimate result. From this point, herniation syndrome will be there. You can see subfalcine herniation and then central area herniation and also uncal herniation, resulting in arterial compression as well, further increasing infarction and edema. Finally, it compresses the brain stem and also cranial nerves and also leading into secondary brainstem hemorrhages, resulting finally death if untreated. This slide provides a very good summary for you all, and you can read it up later on. And I recommend these 3 slides also you can read leisurely. Now it's time to discuss about diffuse traumatic injuries. It could be mild or severe in form. For the mild one or mild traumatic brain injuries, example concussion. For severe grade, diffuse axonal and vascular injuries. First of all, let's discuss about a scenario to explain about the incident of concussion. Right. So now imagine a motorcyclist is traveling from his home to his workplace, and he had collided or met with an accident at a certain place here. So now when I inquired, he mentioned that he can remember passing of a famous supermarket at that point. So he has come out from the home and he can remember that he was passing a famous supermarket. But after that, he can't remember anything about any collision and he is unaware about anything. And onlookers had explained that he met with an accident and then he lost his consciousness. That means he was not responsive for a while. That means maybe a few minutes. And also he got up from the place and he was walking around here and there. However, onlookers had taken him to the hospital. Now he is at the hospital. Now what do you think about this period now? If I happen to ask about the history, now he will explain to me that he can remember that he was coming out of the home and getting into the bike, and he can remember that he was passing a famous supermarket, and then he might tell, then he will explain me, now I know that I am on hospital bed. So what has happened during this time? Now obviously this time is for loss of consciousness, that he is unaware of anything, no response, nothing. But what do you think about these two places. These are the places where the person is conscious actually, but he can't remember the things that what had happened. Since this period is before the accident, so this is the place of accident. Since before the accident, we term this period as retrograde amnesia. When we come to this place, this is actually after the accident, and as a result, we term this period as anterograde amnesia. Now, onlookers had nicely explained that he was moving around and he was talking and he was complaining of bleeding and all, but actually he can't remember anything. Here also, the CCTV camera shows that he was riding his bike very well, but suddenly he collided and he is conscious at that time. Now you can understand. So these are the two periods where the person didn't get the memory. Neurologically, it is explained like this. Within the period of this retrograde amnesia, the person has got the memory already, but he can't access the memory. Whereas to that, in case of anterograde amnesia, he has got the memory, he has experienced certain incidents, but he can't store the memory and to recall later. You can read this slide leisurely, and I have explained everything. Let's summarize about concussion. Concussion is a clinical syndrome characterized by an immediate and transient alteration in brain function, level of consciousness resulting from mechanical force or trauma, usually caused by blunt force impact to the head. And also, concussion is a mild type of brain injury that produces reversible neurological impairment without demonstrable structural brain damage. That means the software of the brain is upset, but not the hardware parts. Mechanism is acceleration, deceleration, or rotational injury leading to functional disturbance of the brain. What's the definition? It's a type of mild traumatic brain injury resulted by direct or indirect head trauma. Usually it is direct trauma, resulting in immediate and transient loss of consciousness, usually less than 6 hours. Nowadays it is mentioned as within in minutes, with no microscopic or microscopic structural damage. It always followed by amnesia, and retrograde amnesia is, however, almost inevitably associated with concussion. Concussion may be followed by a post-concussive symptoms characterized by early and late clinical symptoms such as headache, dizziness, unsteadiness, and anxiety. It is a retrospective diagnosis at the time of your examination, hence the patient should be clinically normal. I just add this slide to read leisurely if you are interested in. It is very interesting to study about medical legal importance of concussion. What is the category of hurt during the period of concussion? There is an existing threat to the life by falling the tongue back, causing asphyxia, and also by airway obstruction due to the aspiration. Compensation syndrome. That means the person is going to complain about his post-concussive syndrome symptoms for more than 3 months, often to take compensation or for claims for financial gain. Second impact syndrome occurs when a person suffers a second head injury before fully recovering from an initial concussion. This second injury can lead to rapid and severe brain swelling. Fourth one, it can lead to automatism. Automatism means a state in which a person performs actions without conscious awareness or rational control, though he appears normal externally but not responsible for their behavior. As I have explained you earlier, within the period of concussion, though he appears as conscious and rational, but actually he is not. Retrograde amnesia is a protective mechanism where memory of events before trauma is lost, shielding the individual from psychological stress. Imagine a situation where he is going to remember the highly traumatic incident frequently. How can you can understand the uh, trauma that he is going to face frequently. Moving on to the diffuse axonal injury, by definition, it is a form of traumatic brain injury characterized by widespread shearing and stretching of axons in the white matter tracts, typically caused by rotational or acceleration-deceleration forces. As per the pathophysiology, the rapid acceleration or deceleration causes mechanical shearing between tissues of different densities of the brain, that means gray versus white matter. These shearing forces damage axons, leading to axonal swelling and eventually disconnection with the time. In normal axons, uh, amyloid precursor proteins or APP, especially beta amyloid precursor protein, is transported along the axon by fast exoplasmic transport. When axons are injured, as in DAI, this transport is blocked, accumulating amyloid precursor protein at the site of the injury. Therefore, amyloid precursor protein immunohistochemistry is used as a marker of axonal injury, often visible within 5 to 6 hours after trauma. To have an image, now this is a very good image that I have taken from the internet. According to Adams et al. 1989, there is a classification that means there are 3 grades. The first grade, that means we can't see anything, axonal injury in white matter of cerebral hemispheres. In grade 2 through grade 3, the severity is more and more. So this is a case of case 3 ideally, where you can see certain accompanied hemorrhages as well, closer to the midline and also in the white matter. And also on the rostral pons as well, you can see certain hemorrhages. Another image to show, here again you can see corpus callosal bleeding here and also certain widespread punctate-like hemorrhages in between the cortex and white matter. Mostly the hemorrhages can be seen in the white matter, suggesting a severe form of diffuse axonal injury. Let's have further detail about anatomical distribution of diffuse axonal injury. Lesions are typically found in the corpus callosum, parasagittal white matter of the frontal lobes, internal capsule, cerebellar peduncles, and dorsolateral midbrain or upper brain stem. The pattern may be diffuse, but certain regions are more vulnerable due to differential tissue movements. What are the clinical or forensic significance? It is strongly associated with immediate loss of consciousness and persistent vegetative or comatose states even when external head trauma is minimal. You can understand the severity of the injury or diffuse axonal injury. It explains the cases of sudden collapse after trauma where there are no large focal lesions. The brain is macroscopically basically normal, but the person is going to collapse suddenly. What is the forensic relevance? It lies in recognizing that severe brain dysfunction can occur without gross macroscopic evidence, making microscopic and immunohistochemical studies crucial. Now you can understand diffuse axonal injury. Most of the time we have to identify with histopathological methods such as immunohistochemistry, as I have described earlier. What are the circumstances? Usually it is seen with high-speed road traffic accidents, fall from height, rarely with assaults with shaking injuries. The interesting counterpart of diffuse axonal injury is diffuse vascular injury. By definition, diffuse vascular injury is a form of traumatic brain injury caused by widespread tearing and rupture of small intracerebral blood vessels, usually due to severe acceleration, deceleration, or rotational forces. Unlike diffuse axonal injury, which primarily affects axons, here in diffuse vascular injury, it is characterized by multiple small hemorrhages throughout the brain parenchyma. You can understand, in case of diffuse axonal injury, you experienced hemorrhages in severe cases near to the midline. Here you can see the diffuse brain multiple small hemorrhages. What is the pathophysiology? It is caused by mechanical stretching and rupture of small penetrating vessels and venules, but not axons. It leads to widespread hemorrhagic lesions, especially in white matter. It can occur together with or independent of diffuse axonal injury. To discuss further about diffuse vascular injury, it looks like widespread petechial hemorrhages predominantly in frontal lobe. What is the microscopic appearance? It appears as perivascular hemorrhage with surrounding tissue necrosis. It may be associated with axonal damage as well, but vascular rupture is the primary feature. What is the forensic significance in diffuse axonal injury? Here also very similar to diffuse vascular injury, immediate unconsciousness is the result with poor survival. It is seen in high-speed traffic accidents and falls that is associated with acceleration, deceleration and rotational forces. At autopsy, we experience multiple hemorrhages as we have described earlier, and diffuse vascular injury must be distinguished from diffuse axonal injury because the pathology is different. In case of diffuse axonal injury, axons are damaged, but in case of diffuse vascular injury, vessels are damaged. Finally, we have reached to the end of the presentation. Now it's time to attempt the practice MCQs, which is included in the part 3. Thank you.